So there are a lot of guides available and resources and toolkits, and I just wanted to mention some of those here. The IHI, the Institute for Healthcare Improvement, right? Kind of a think tank around improvement in healthcare, all kinds of looking at strategies and research and so forth, and working across entities. And they've worked with groups like the Agency of Healthcare Research and Quality and some other Kaiser and a bunch of groups, and have developed a lot of toolkits. There's a toolkit, this one happens to be for Medicaid readmissions, and all of these, you can go online and download them at no cost. Here's a guide for improving transitions from hospital to skilled nursing facilities. This is another a re-engineered discharge toolkit. There's one for hospital to clinic. So these are really good, and in terms of trying to do some analysis around the areas in which you work and develop some strategies around preventing admissions and readmissions, I'd encourage you to go out and look at some of these. I'll set these over here if anybody wants to look at them at break. But just a lot of really good tools. Here's the table of contents from the one that was around Medicaid, and they can be used from high level, from the administration of a hospital or clinic down to the bedside, in terms of where how we can intervene. One of the things that, one of the most useful tools, I think, in looking at how we prevent readmissions is to use root cause analysis. And we're all familiar with what that is. There are a lot of different tools, IHI and this group, the AHQR, have developed some tools. These were basically developed for hospitals to do readmission interviews with patients and their families. They can be used across the spectrum. And we have been doing that here at CareOregon with our transitional care program for the last year and a half or so. We've modified the tool a little bit to make it more pertinent to kind of what we're doing. But these are really good analyses to do. Every population, like Mariah said, is different. But what's really probably not shocking is that what we as healthcare providers, as clinicians, as people that work in healthcare field, what we classify as the reason for readmissions is frequently not what the patient and their family will tell you it was. So the interview of the patient and family can really highlight what the real causes were. For instance, we tend to use the word noncompliance a lot in our professions. So, and noncompliance for us means that they didn't get on board. They didn't do what they were told. Frequently, patients will tell you that they didn't do it because they were too sick. And with this interview tool, we hear that a lot. So things like the clinical review, they readmit to the hospital, and the chart notes say they came back in because they didn't take their medications. And what we'll learn from the member or the patient is that they couldn't get their medications. I was too sick. I couldn't get to the pharmacy. I don't have a ride. I couldn't get to the pharmacy. Went to the pharmacy, and the pharmacy orders were messed up, and it was a Saturday, and they couldn't reach the people that had ordered it, and I couldn't get my meds. There's cognitive and language barriers. And so patients are frequently confused. They went into the hospital with these 2 inhalers. In the hospital, they played around with all these. They sent them home with prescriptions for different ones, and they don't know. Am I supposed to take all 4? Am I supposed to take these two? What I do? Sometimes they then take all of it. Sometimes they take none of it until they can figure it out. We might say that they're back in the hospital because they didn't follow the instructions. We sent them home with a discharge summary and told them and taught them what to do when they went home. The member may say, well, you know, I didn't have an interpreter. I didn't understand what they were saying. My instructions are in English. We have frequently, there's cognitive decline that sometimes we don't pick up on in the clinical setting because we don't have a baseline, or we get sort of a healthcare bias. We think, oh, they have depression, and so we're not looking for other cognitive decline. We frequently will say, well, they didn't show up for their follow-up appointments, and so now they're back in the hospital. But frequently, patients will tell us, I was too sick to go, I didn't have a ride. Ride to Care was set up to come pick me up, they didn't show up. So lots of barriers for them just getting to those follow-up appointments. So, where are we? Okay. So we're going to walk through a real case. I have a transitional care nurse here who this was her actual case that we reviewed in our root cause analysis group. So this member was I don't know where I put my note on this guy. I think he was a 82-year-old gentleman who had was admitted to the hospital, who had been very independent, living with his disabled spouse, and a daughter and her family, had been basically healthy, but was admitted to the hospital for bradycardia. He had a first-degree AV block. He was admitted, I believe, on a Saturday. On a Sunday. They did a workup and so forth, and it put in a pacemaker. They wanted to send him home on Thursday. He had just had the pacemaker implanted, and the family was very nervous about him going home. Actually, they wanted him to go to a sniff. The family didn't feel like he was ready to even leave the hospital. They felt that his symptoms were kind of the same as when he admitted. They did not use an interpreter in the hospital. This gentleman was Vietnamese speaking. His son spoke moderate English, so they decided to use family as interpreter. And what happened was they ended up keeping him until Saturday in the hospital, discharged him on a Saturday, and instead of sniff, they sent him home because family thought they were trying to send him out too soon. Hospital thought that they didn't want him to go to a sniff. So they sent him home on a Saturday morning, and he did not feel well. And he was back in the hospital back to the ED on Wednesday. So in the root cause analysis, you can see that the question was, why were you admitted to the hospital previously? And the gentleman and his family said that he had been feeling sick for a few days. He woke up dizzy, stomach pain, nausea, vomiting, and so his family took him to the ED. When asked, how did you feel when you left the hospital on that first discharge, they said, well, he went home on a Saturday. He was still confused, he was weak, he had diarrhea, he was able to walk a little bit better, but he was still not weak enough to care for himself. Where did you go? He went home to live with his family. Home health had been ordered, but they never contacted the family and never showed up. There was the confusion around the sniff. And so he didn't go to SNF, and he was obviously sick enough that that was the appropriate level of care. Did you have any questions or concerns? The family said they were concerned about the unresolved symptoms. He was going home with the same symptoms with which he was admitted. They were able to get their medications. Did you need help taking care of yourself? Yes. He was weaker. He had trouble walking. The son who does not live with him was having to come and help they were having to provide 24-hour care. The families increased their support to 24-hour supervision. When did you start to not feel well again? The day of discharge. He never felt well. When they got home on Saturday, the pacemaker equipment malfunctioned. Oh, sorry. Thank you. When he got home on Saturday, the pacemaker malfunctioned. He was weak. He had nausea and vomiting, fever. He began to have increasing confusion. Did you call anyone? Doctor, nurse, clinic? They called the cardiac surgeon, who couldn't help with equipment. They called the equipment company, but it was Saturday. They called the cardiologist and had an appointment to see the cardiologist on Monday. So he went through the weekend without the pacemaker working. They saw the cardiologist on Monday, and they went to the PCP on Wednesday, and he was admitted directly from his clinic office. Did you try to manage your symptoms yourself? The family said they advocated to try to get help with the equipment. They fed him foods that he liked, even though he had nausea and vomiting, and they discussed different methods for trying to control pain. So in the end, the reason for going back to the hospital was they're numerous, and let's have some of you throw out what were some of the barriers that occurred for this member that we could, and the idea is to drill this down to what were the actual things. It wasn't that, it wasn't what the member was not doing, but what are their barriers? Are there patterns here that we see that we can intervene and prevent this from happening again? And sometimes these are at an individual case level. He's back in the hospital. We try to do these interviews upon readmission, because if there is something that we can intervene with now to prevent this from happening on this current admission, we want to get on that. Sometimes they're system levels. Sometimes they're barriers with things in the community like rides and so forth. But anybody? Mm-hmm.
When we work with our hospital, in their discharge team, they actually have their home health director as part of their care team. So before they're leaving the hospital, she's actually making direct contact with the patients, and they're planning on what it is, and that information of if they can't get out there for 4 or 5 days is brought to the care team so that they know how to decide their discharge plan.
That's great. So home health, having some home health available prior to discharge to help in the care plan. This is something that we frequently see on the outpatient side. And what's interesting is, and what's important about having these kinds of dialogues across the healthcare spectrum, is that we know what we know from our viewpoint, right, in the space in which we're working, but we don't always know what happens when the patient moves to the next phase. So if I'm in the hospital and I'm planning a discharge, it may look really great and I've got all the things in place, but I don't know what happens once they go through the door and out into the community. So this example is very common in terms of home health, and I'm not pointing fingers at anybody. It's just that, when somebody goes home on a weekend, home health with orders faxed to home health is not going to show up on the weekend, and frequently home health they're not able to get to that referral for 2 weeks. And sometimes we find that it didn't show up on their fax machine, or it did, but it turns out they don't take our insurance. So there are lots of barriers to having home health there and available. So that's a good strategy. What else?
I think number one, it would have been really, really important for the hospital to get a Vietnamese interpreter for the family, like, immediately. And I know that's difficult, but throughout the whole admission, there just should have been somebody to make sure communication was on target.
Right. I think we have time constraints. It's like we got to go. It's going to take time to get an interpreter. It takes twice as long to work with an interpreter because there's double, triple speak. But in healthcare, it's really important. We make assumptions about people's level of understanding and the communication. And medical speak, clinical speak, is very difficult to translate if you don't speak the other language. So you're right.
Well, there's almost two language barriers. Even if your English is a primary language, if you're not well-versed, or even if you are well-versed, at one of the CCO conferences, a woman who's an MD, who's a PhD and runs a health system, was saying when she was a patient, she was having trouble navigating, and she's English as a primary language, and she works as an administrator over a health system, and she still was having trouble navigating. So when you have an actual language barrier plus you don't have an advocate that understands the health system, either yourself or someone else, you really almost have two language barriers, and that is going to create significant confusion, as seen in this case and lots of others.
Exactly. Yeah, there was obviously not clear communication going on around the location for discharge with this family.
I'm going to play devil's advocate in terms of the interpreter situation because in some cases there can be barriers to care when there is an interpreter involved, and depending on the community that the patient lives in, depending on the culture, there are things that can get in the way that may cause problems that we don't know about and can't anticipate. So I think there's issues on both sides. The family may not have felt comfortable with a person outside of their family, discussing the medical concerns or the personal business or things like that. So.
Okay. Thank you. What else?
I think the pacemaker malfunctioning would be a huge cause of stress and could potentially exacerbate other symptoms like nausea or not wanting to eat.
Right.
I just can't believe that nobody could figure out who to call over the weekend, help this patient get a 24-hour access to a support person.
Yeah.
I don't think pacemakers are just Monday through Friday. I hope they're not the companies.
No, but this is not an uncommon problem. DME, medical equipment is frequently a barrier and is frequently the reason why somebody goes back to the ED in the hospital. Again, it's sort of like home health. It's not uncommon for our transitional care team here to check in with the patient, the following day after their discharge, and none of the equipment was at their home and had shown up. And the equipment company, when you contact them, they say, well, it's, we only deliver on Tuesdays. They went home on a Wednesday, so it's not going to get there till next Tuesday. That's not uncommon. Or they lost the orders. So the equipment is definitely a barrier.
To that,
Yeah.
with the pacemaker, my wish would be that there would have been really detailed instructions on that issue to get yourself to an emergency department or something like that.
Agree. Again, probably they were in English. And it goes to how do we help patients also learn how to advocate for themselves, right? They actually felt that he wasn't ready. I'm surprised they didn't take him back to the ED over the weekend, right? But they were encouraged to like, well, we'll see your cardiologist Monday. So they kind of limped through to that. But I think frequently people don't know what to do or how to advocate for themselves or how to access, how to problem solve. So part of that goes to some of the transitional care and you know, giving them the tools when they leave the hospital or shortly afterwards about if this happens, do this. And I mean, I think that's a good practice when we're transitioning people, is to give them the information that they need so that when this happens, they kind of know what to do. We inform them of that.
Especially with something like a pacemaker, you would think at some point somebody would say to them, listen, this is, you know, amazing technology, but it's a machine.
Yeah.
If it stops working or you feel it's not working, here's what you do. I
Yeah.
mean, that should be something that every member of the family hears loud and clear, right?
Right, right. Oh,
I was just going to say, I mean, again, you know, just the double-edged sword of that, I mean, is, you know, the amount of detail is lovely, but when they go home with an after-visit summary that's 15 pages long, because they've had a major medical condition that change in the hospital, and they go home with all new meds and all new treatments and all new durable medical equipment, it all has to be there, but, you know, it when you add in health literacy
Overwhelming.
issues or even illiteracy or language barriers or just medical competency, I mean, it's all there, but it's, you know,
Yeah.
there's so many factors to consider.
and it's overwhelming. And with this family, yeah, the member of this patient obviously didn't feel any better. And the family was very concerned, and they were stressed out because he had been completely independent and healthy. And now all of a sudden he's confused, he's weak, he can't even ambulate by himself, you know, and there's all this going on, and you're just going to go home. And so, yeah.
I just want to quickly add, too, that for a lot of patients, there are cultural concerns, too. So it sounds like the family for this patient really wanted to advocate for him and really wanted to help with equipment and help with, you know, wherever he was discharged to. And so it's you know, yes, we want to make sure that the patient feels empowered to, you know, make decisions and go home with all the information, but it's also making sure that the family feels empowered to help the patient outside of the clinic, especially because that's what that situation demands. So it's up to, you know, healthcare workers to make sure that the family is supported as well in supporting the patient.
Exactly.
I have one more comment on cultural barriers or impact, and that is, well, kind of cultural. When you go to the hospital, there's trauma involved, and there's a certain change in the brain that occurs in terms of adrenaline and cortisol, and that impacts memory and ability to learn and remember on the part of the patient and on the part of the family. And gonna put a plug in for someone who has some biopsychosocial background to be able to kind of work with the family and see if there are any other barriers or kind of problem solve to see if those can be reduced, because that's all going to impact their readmission. And that's normal across the board to any human being to have a major medical condition.
Good point. You still have, but she's had her hand up a lot.
I thought one positive was that he did have, 2 follow-up appointments. But sometimes when they see specialists, there's sort of a narrow view of what needs to be addressed when there's potential to say, has your home health started, or what other things are going on, or more communication with the other clinic.
Yeah, that's interesting because they saw the cardiologist and then Wednesday they go to the PCP who says, whoa, you need to be in the hospital. So whatever happened, it wasn't resolved at that specialty appointment. Yeah. And I think sometimes that's, in their primary care in their medical home, you know what the baseline is for a member too, right? And so you can be more responsive and reactive to that. Yeah. Yeah. Mm-hmm.
Do you know if this member had a phone call from the hospital?
Yeah, I
after
don't
discharge,
know.
or did they have a pharmacist, anybody reviewing things?
It didn't sound like it, but those are the best practices. I think another barrier is when we have really sick patients at discharge on a weekend, and because resources available on weekends, nights and weekends just are not the same as they are during the weekdays. And you'll hear more about that later when, from Maya and Anthony too, and as well as from the SNF. So, And care management department, right? And frequently those late Friday through, to Monday morning discharges are like, they're fast, you don't have access to even the community people you need to talk to set things up. So and then when patients get home, the doctor's office is closed, the person who discharged from the hospitalist at the hospital is no longer on shift. There's all kinds of complications. The DME company is closed, so we're closed. I mean, as a health plan, we try to do follow-up when we know that they've discharged, but we're not here Saturday and Sunday either. So I think those are things to think about. The other thing was that is, oh, yeah.
Sorry. I just had a question, and you may not have the data about it, but do we know local area hospital, the discharge rates on the weekend, on Fridays, on evenings, and everything like that, to see if there's a balance or a right fit in terms of?
Do you know anything, Carl? I don't know, or
They
cases.
spike on Friday afternoon. Yeah. Everyone wants them out by Friday.
Yeah.
I don't have data on that, but I would concur with that.
Yeah.
Feels right.
Yeah, I would say, our transitional care team here kind of feels like Fridays are like, oh, we got to get everything ready so that they're going to be okay for the weekend kind of thing, so. Mm-hmm.
I kind of wanted to play devil's advocate because, in a way, I wonder if it was a perfect storm because I'm sure the hospital did not discharge this person knowingly with a
Right.
malfunctioning pacemaker.
Right.
And he did have an appointment on Monday and Wednesday.
Yep.
And I'm assuming that his vital signs were reasonably stable and, he'd been
Actually
in for.
not. And that,
Oh, okay, well then,
and so that.
okay, I'm done
Yeah.
playing devil's
Yeah.
advocate, but there was a lot that was good.
That's the word that keeps rising up though, through this whole narrative, right? Is I can't tell how many times I've heard the word assume get used in
Yeah.
there. And I think that we assume a lot of times that, okay, we gave them all this information.
Yeah.
They must understand us, right? And I think that's
Right. Well, and
a
the other
slippery
thing
slope.
was that this pacemaker was probably installed on a Tuesday, and they wanted to send him on Thursday, so there wasn't even hardly more than 24 hours to see how he was going to adjust to that, and we'll talk about that in the next bit.
Hello. So I wanted to speak to some successes. We've got our community transitions team in place in the 4 Providence hospitals locally. And so they make a bedside visit and arrange for a home visit within 48 hours of discharge. So this guy would have been seen at home probably on Monday. They would have found out that the pacemaker they would have been looking at red flags from the discharge summary, so they would have been checking on the DME and the home health and the ride to the doctor, and would have been helping the family, empower them to advocate more strongly and look at their options, and any other social determinants going on. And they might have been able to intervene, get something going faster.
Yeah.
And they've been having recently, as low as 4% readmission rates on the folks that they're visiting in their homes following a
That's
hospitalization.
great. You want to tell them what your program is?
Yeah, it's the Metro Community Transitions Program, and we sponsor it through Multnomah County Aging Disability Veteran Services, but it's available in the metro area, Clackamas, Washington, and Multnomah County. It's been hugely successful at lowering readmission rates, working primarily with Medicare patients, but also dual eligibles for several years.
Yeah.
How do we find out if our patients have that resource? Because I found out like a month later that my patient was working with someone the whole time.
Well, we're contracted to work in all the 4 metro area Providence hospitals.
Do you notify the PCP's office or?
Well,
does only the patient?
they work with the coaches work with this patient and their family to empower them to self-advocate and be more engaged in their own health care. So typically, it's not our staff making the calls. It's us coaching and supporting the family and the patient to make the calls and follow through on things. So we're sort of behind the scenes in that way.
So, as you can see, there are a lot of people involved in helping transition and care coordinate for patients. Jan's been leading a group for the last year plus in the metro area with representatives from all across the community and the spectrum of healthcare related to transitions and trying to, kind of put together a map of what people are doing, what's available, how can that,
How we can work together better, coordinate, collaborate, communicate across systems.
Right. So see her if you're interested in this work.
I guess I'm curious, one of the things I think that is a benefit of the clinic connecting with the hospital system is the hospitals also have a hard time identifying who the PCP is through their electronic record system, and they often are dependent on whether the patient identifies their PCP at the time of discharge.
Yes.
And so that we've found to be a barrier, one of the things that the hospitals are asking for better information on. Sometimes pre-managed can help, but it's also about whether your organization uploads your own patient data to pre-managed to match.
Right.
And then we have a lot of patients culturally that have multiple last names, first names, use different names. And so if they're not a direct match, they also don't hook up. But the benefit if you can hook up or at least connect and find out if it's your patient with the care managers is that they will connect you to the primary care provider. And then for our clinic, we've actually given them our providers after our contact number for the clinic. So this family could have also called their primary care office and spoken with a medical professional who would have access to an interpretation line with Vietnamese to be able to counsel these patients about what the appropriate action could be over the course of the weekend. And that's what they're there for.
That sounds really good. The one other thing I wanted to say here, and this is something that we as a health plan see not infrequently, is when patients are in the hospital and we think that they're going to go to SNF, that's a level of care that they require, and then at the last moment, they go home for a variety of reasons. And it's usually because the patient doesn't want to go to a SNF. But what happened, those are cases where I think then we need to scramble to do what we can to support them at home. And so this was one of those other situations. He should have gone to SNF because of the communication barrier there. He went home. And then the support that he would have gotten at the SNF wasn't in place at home. And so those are really difficult situations. We try to anticipate those a little bit to jump on them, but it's hard to know. So we're gonna leave this, but this is just one case, and we're gonna present. We had a few that we were gonna present just to kind of demonstrate, but I think this one gives you the flavor. But it also this is the value of doing these root cause analysis, but not just the typical root cause analysis that we do in healthcare, where it's from our clinical lens and our clinical view, but how did the patient and their family see it? Because that's where it really matters, right? So, okay. I'm just going to talk real quickly, touch on a couple of studies that have been done recently that, just to make you think about this a little bit. So this study was published in the Journal for General Internal Medicine in January of 17, and it's been reviewed and hashed over by a whole lot of people who were like, yeah, whatever, and then, but validated over and over again. And it's around vital sign instability on discharge and its impact on readmissions and 30-day readmissions and mortality. And so, again, this patient we just talked about did not have vital sign stability at the point of discharge. By the way, that patient, after they went back in the hospital, they got him stabilized, they got the pacemaker working, they validated that his vital signs were good. He's home, he's back to his independence and full functioning level. So, yay.
Pacemaker will do.
Yeah. So this is the criteria for the abnormal value for vital signs that they used in this study. So, if in the 24 hours prior to discharge, if one or more of these is not stable, then that's a red flag. So temperature of greater than equal 37.8 centigrade, a heart rate of greater than 100. Respiratory rate greater than 24, systolic blood pressure of less than 90, and O2 sats of less than 90. And I think you could probably consider if there were some other vital signs that weren't stable, that would you'd put those in the same bucket. But it's significant. Almost 1 in 5 patients are discharged with vital sign instability. So think about that. And the most common one was heart rate. Having any instability was associated with a significant increase in a 30-day mortality and readmission. And the greater the number of instabilities you had, the number of factors, the greater your risk of mortality and readmission. So almost 17% of these patients with instability that had one vital sign instability at discharge either died or was readmitted in 30 days. If they had 2, it was a 21.2% of readmission or death. And if they had 3, it was 26%. So think about that. I mean, this is kind of common sense, and that's pretty significant. That's almost it's almost 20% of patients being discharged from hospital, and this is an easy thing, a very easy thing to address.
And I think one of the interesting things, I know I have some inpatient pharmacists here. We've all seen that patient where they slam them with metoprolol and send them out 6 hours later when the AFib's, the heart rate's down, or it's target dose for heart failure, and they want to get him home, and you're kind of like, boy, I don't know, it was kind of unstable yesterday. So this is a really simple way. Medications can be impacting this, right? So some underlying physiology can be impacting this. Vital signs are just a really objective way to say, this hasn't been stable long enough, I don't think this is a safe discharge, whether that's medication related or otherwise.
Exactly. Yeah. So think about that. And I'm sure case management can just impact that, like, doc, they can't go home, right?
No problem.
Yeah. So will you get all over that? So this is, again, kind of a no-brainer. But when we need to get the bed opened up quickly, or sometimes patients want to get out quick too, I think we need to try to be a voice of reason in there. This is another one. This was in a long-term skilled medical journal published in March of 2016. around about hospital readmissions from SNFs. So, and what they found was that almost a fourth, 1 in 4 of patients who were readmitted to the hospital from a SNF, almost 1 in 4 were readmitted to the hospital within 30 days. And half of those readmissions were within the first 2 weeks. Patients who were readmitted to the hospital from the SNF were twice as likely to die within 30 days of hospital discharge, and 4 times as likely to die within 100 days of discharge. Pretty significant. And patients who experienced readmission to the hospital were less likely to even return to the community at all.
I wonder if some of this is that these people were actually dying, and it was a disjointed inability to address their end of life care in a holistic way because they're flopping all around. That's often what I see, that they're actually in the dying process.
I think you're absolutely right, and that probably does impact that. Meryl Manley will be here talking about SNFs in a little while, but I think there are also a lot of unsafe discharges, transfers to SNFs, and in some part because I think other primary care and specialty care and hospitals don't necessarily understand SNFs and how they operate, what they're working under, what their orders are. I remember talking to a group of hospitalists one time who thought that there was a pharmacy in every SNF, and it's like, no. So when you don't send orders, when you send orders with the patient as they're rolling into the SNF, then they have to go through those, and it goes to a pharmacy over in Vancouver or, Gresham, who puts it together, and maybe 8 or 10 hours later you get it, and so it might have been as much as 24 hours for that patient to get a med. And then maybe the orders weren't accurate, weren't correct, and so there are a lot of barriers too why patients go back. But I think this is an area that we really have to do some work on. We haven't done a lot of work around that transition to SNF, and I think there's opportunity here for us to look and focus on on patient selection for SNF, and sometimes maybe it is we need to think more about end of life, about palliative care, advanced illness care, and hospice, and et cetera. So, as well as there's the processes of transferring patients to skilled facilities.
Jane, I just really wanted to reiterate that piece about earlier palliative, earlier hospice. And I know that probably, Dr. Stevens, you'd probably know this better than I, but a lot of stuff is coming out just recently about end-stage renal disease and how they aren't on palliative care or hospice until days, and they die, like within just 2 days being on hospice. And so I think, especially when people are going into SNFs, that discussion at least needs to be addressed earlier. And I think we're improving on that.
I think we're getting better, but that is an area where we as healthcare providers and clinicians and healthcare systems, we need to really focus some energy there and do a much better job of helping patients, identifying patients, and starting to have those crucial conversations with them around planning. And there's a lot of misinformation and misunderstanding around palliative care. What we're tending to call it more, rather than palliative care, is advanced illness care. People generally think of it as end of life, and it's hospice and so forth. But it's really about helping patients set goals for what they want, and help to support them when we know that they're on a trajectory towards end of life. And so it doesn't mean we stop stop treatments and do other things, but it is about helping them plan and achieve their goals for that time of their life. So, yeah. Okay. Any other questions? I think we're done with this segment.
I think you're right. Okay, we got the stage set pretty well. Let's give a big hand to Mariah and Jane.